of the day is about delivering value. And clearly, a key enabler for that is around information technology, systems, and the sharing and use of information. But there are many challenges, there are many risks, and I think that there is not just the what we need to put in place, but then how do we use it? And those are the kinds of issues that we'll be exploring in this session. So I'm going to ask August first to maybe kick us off with what you see in this rapidly changing environment and rapidly changing technology. How do we build, what are the systems that we need to have in place to enable us to deliver better value care, higher quality, and more efficient care?
Thanks, Vivek. And let me give you just two sentences on context here, because I think many of you know Dell as a company. We make 50 million IT devices a year, but we also are the largest health IT services firm in the world. And so I'm coming at you from the perspective of actually running clinical systems for hundreds of hospitals every day. And what we do we're trying to fulfill what's very much an unmet need. We spend most of our efforts in the US, but it's a global problem. Health IT, there's not a good foundation. So you're starting from building on sand in many cases. Many hospitals don't have even connected clinical systems, right? They have islands of systems that have data that you have to walk with USB sticks, the data in between departments. And then, that data is also not available in a very easy to use way for medical professionals to make good decisions. Because that data has never been in one place, and it's hard to get to. And then finally, where things are headed, right? Once we've done that and built all the foundations, actually have our information in a computer, and everybody can get to it, and all the various systems are connected. How can you start to make the use of that data and make informed decisions around taking a longitudinal view of a patient? In terms of population health, in terms of looking at the performance of your institution or a department or an individual physician. So I think today, in many cases, we're just putting in the foundations in the US. It certainly varies by market around the world, but in general around the world, I think the average is we're just getting the basic foundations in place. And that's not even addressing the challenges around getting the end users, physicians, nurses, other healthcare professionals, to actually use the system as part of delivering healthcare. I mean, the most common complaint I'll hear is it gets in the way of me interacting with a patient, and that's unfortunate. So I think that's where we are, but I think it represents an opportunity. We've made tremendous progress in the last 2 years in this country, and so there certainly are several very good examples around the world where other countries have made tremendous progress as well. But I think on average, we have a long ways to go in the US and around the world with using information to more effectively deliver high-quality health care at a lower price. And that's what it comes down to.
So right there, I think you've touched on a number of both the challenges and the opportunities, and I think we can explore a lot of those. I turn to John now. I mean, I think, EHRs, they start off as kind of a system that kind of often has been cobbled together. I've seen in some places where it's just a means to go paperless is seen initially. But maybe can you talk about some of the things that are possible that you're actually doing that go way beyond that are actually around delivering care in a better way and performance managing care, and maybe beyond that too. So, yeah.
Absolutely. So if you look at this meaningful use program we have in the US, we started off with stage 1 in 2011, trying to get data in structured electronic form to begin with, as you say, lay the foundation. And so then once you have it in structured form, what do you do with it? Well, you want to share it. That's certainly a good next step. But then, ideally, you'd want a learning healthcare system. You can aggregate data and start turning it into knowledge and wisdom. So as hospitals and doctors are now trying to deal with ACA, the Affordable Care Act, they're being told, we are going to pay you not for quantity, but for quality. We're actually going to look at outcomes. We're going to actually ask you to keep patients healthy instead of treat them episodically when they're sick. And does any doctor or hospital have any idea how to do that? Well, Mayo probably. But the rest of the world doesn't. And so we are having to engineer IT systems. I mean, it may sound like these are buzzwords, but cloud-hosted big data, that enables the data retrospectively and prospectively to be mined to help us manage care. So here's an example. Docs have 12 minutes to see the patient. You know, they're not going to be able to look through reams of medical records, put together a completely coordinated care plan, educate the patient and families, and ensure they get this continuous wellness. You need a team. And that team typically would be non-physician care managers who will take data that we aggregate. And as you say, wouldn't it be great if it was all in one normalized database and everyone was talking the same language? Not going to happen. What you have to do is take data from EHRs and hospital information systems and ED information systems and normalize it and place it into a container where it can then be used for care management. So non-physician care manager gets into the office, says today, Monday, 8 a.m., I'm going to work on my diabetic patients. Is able to go against a guideline or a protocol and say, well, of all the 4,000 diabetics that we are seeing, who has not had a foot exam in a year, an eye exam in a year, has a hemoglobin A1C greater than 9, and has home glucometer readings that are trending above 200. I will put a home care nurse into that home to look at activities of daily living and preventative measures, schedule some appointments. The days of just going to the doctor when you're sick and seeing that clinician every 3-4 months are gone. Because today, my fee-for-service business is dead. Here in the Midwest, it's actually still quite good, but in the East Coast, we have 80% of Beth Israel Deaconess patients today in global capitated risk plans. So this idea of collecting data, exchanging data, normalizing data, and then doing care management on large aggregations of data is essential for our survival.
That's very interesting points you raised. I mean, Barbara, you, in the Innovation Center there, you're developing shared care plans. So this is a kind of vision for what you can do and what the future brings. And could you tell us a little bit about what you're doing there and how you're using systems and the information in that way?
Sure. So, you know, I think I said a little bit of context earlier in talking about Mayo and our core value that the needs of the patient come first. And I really come back to that because, you know, we have a revised mission and vision statements that talk so much about not just being there for patients when they're sick, but this whole idea about hope and well-being. I think as we're all thinking about, it's not just when the patient's sick, but it's the longitudinal lifespan. So there's a lot of attention about how do we connect with people beyond their actual events. So when they're coming into the clinic, when they're coming into the hospital, when they're home in their communities. So there are lots of sort of stresses and pressures on the system to think about thinking at more of that systematic level. I think what works really well at Mayo is the core value. If it's the needs of the patient come first, how do we keep that in the center of what we're thinking about? But in addition to the kinds of models I was describing earlier, and I'll talk about a couple of those now more in the context of this conversation, we obviously care a tremendous amount about our staff. So we have almost 4,000 physicians and scientists at Mayo. And I think if a couple of them were here today, this whole thing about what about restoring joy in the clinical practice? So it isn't a very joyful experience to be a physician and a provider in the clinical practice. I mean, whether you're at Mayo Clinic or any place really around the country, I don't know about the whole world. I think there's some parts of the world where the systems seem to be working better. But there are lots of points and clicks. There's piles of information that even when we invest a lot in the pre-visit to try to understand needs of patients before they come and anticipate those needs, they still show up with, 10 inches of data and information and CDs of images and that sort of thing. So how we take all of those data and try to, back to the really important point that August made, I mean, how do we think about the meaning that we can absorb from all of that and what's the best thing we can do for the patient? So it's a pretty overwhelming situation for our physicians and for our care team members. We're thinking a lot about the roles and responsibilities. We're thinking a lot about, again, data, information, the signal from the noise, all of those kinds of things. We're also thinking a lot, again, back to the core value of Mayo, how increasingly we think about our shared care plan with our patients. So we've been doing things like co-creating a care plan. And it's really going to people and patients to say, what does that shared care plan look like? So not through the eyes of our providers to say, here's the EHR, here are the things we can do, here are all the templates. It's what do you really need to try to manage your health and optimize your well-being. And so, we've designed things like that, and we're pretty excited about it. But this whole thing about how does it connect in so that as patients and people are so mobile wherever they are, we connect with them and we change the rhythm of things versus it being about now you're stepping into a Mayo Clinic facility with our EHR and this is the way it's going to go. So I think it's a really exciting time to try to get it right and lots of opportunity.
So I'm interested in this this thing about putting the joy back into the. Now because I think that's been one of the challenges as the growth of data transparency, quality transparency, and protocolization of healthcare, is that it can suck the joy out of or the artistry people may feel. And also, I think what you say is right, that often the IT systems can be seen as a hindrance to work and a negative thing. So is that a technical issue? Is it about having smoother enabling systems that or is it a cultural thing, or a bit of both? Open to anything.
Sure. So why don't we start with the usability of today's electronic health records? I would gather for anyone in the audience, if you go to Amazon.com and decide you want to order a movie, it'll take you 1 click, maybe 2. Try ordering Tylenol in an EHR. 47 clicks later. Come on. Tylenol, 400 to 600, PO, Q4 to 6, PRN pain and fever. How hard is that, really? And so we have EHR systems that were sometimes designed by people who used to work for financial services firms. They don't quite understand the workflow. And they certainly have followed federal regulatory mandates to the letter. And so if the federal regulatory mandate says there's a quality measure about stroke, we need to know, Mr. Smith, did you feel weak 1 hour and 15 minutes ago or 1 hour and 59 minutes ago? So now in the middle of the doctor documenting, pop-up, ask Mr. Smith when he started feeling weak. So suddenly the whole experience becomes mired in federal regulatory requirements and non-doctor friendly workflow. I mean, usability is a huge problem. Another issue, as you point out, is the amount of information, but not exactly the amount of wisdom. Mm-hmm. And that is, as we do more and more healthcare information exchange, we get lots of images and lots of text and lots of structured data. If you have 12 minutes to see the patient and do everything that's right, the computer really needs to say, I have digested all the information about this patient. Today's visit should include the following 3 things. And this is because of whether it's quality measurement or care plans or protocols or whatever, putting in front of the clinician, of course, with patient preferences taken into account, the to-do list. This is alerts, reminders, and decision support. Most of our EHRs, in some ways, are glorified word processors. They don't include that level of cognitive assistance. Now, there are cultural barriers. So I do look at today's Harvard medical students. I'm a Harvard professor. And there isn't a single Harvard medical student without an iPad. Whereas, if you take your average, 64-year-old cardiologist, I'm sure, again, doesn't happen at Mayo, but I had one who came up to me and said, the rat on my computer is broken. I said, you mean the mouse? Oh, yeah. So the adoption of technology, the fluidity at which you can put data is different culturally. Mm. And sure, as a physician, I can tell you, I was trained as an artist. What do you mean you're giving me a protocol? I'm smarter than any protocol. But I think we are discovering as a society that standardizing care, again, with patient preferences in mind, actually enhances quality and enhances safety. So sure, in 20 years, the whole age-related technology adoption thing will go away. In a few years, standardization protocols, guidelines will go away. But the usability, we just need to reflect on horrible EHRs we have today. Everything I host is cloud-based, mobile-friendly, HTML5 web-enabled, as opposed to, look at the commercial vendors of EHRs in America. Visual Basic, state-of-the-art for 1995. That's the reality.
Well, and you made the point around the artist. It's the art and the science, right? And one of the cultural barriers is, I think, getting the physicians to go along with, let's focus on taking as much science in a easy-to-use way so that you can focus on the real art, right? Versus guessing what we've tried before, what this patient's had done to them before, how they're trending, and really focus on what's appropriate for that patient. Because there's a certain amount that any protocol can get you for a given patient with a given condition, but then the decision tree starts to get really complicated with looking at the human factors and what's appropriate in terms of tolerance for pain or nausea or whatever that situation may be. And that's where the art really comes into. And I think that's where the doctors probably do the best, right? Which is in figuring out how to bridge the science to what that given person needs. So ideally, what you stated, the computer should help us by digesting it all, putting it all up, and say, have you thought about these things? Let's make sure we walk through this. It's more like the overused analogy of the pre-flight checklist, right, as a pilot. But it does then allow you to focus not on did I miss anything, but you as the patient, and how can I? And so I think the cultural challenge there is getting physicians to. I'm not a physician, so it's difficult for me to say John or Vivek are probably better to focus on well, but to feel comfortable with the standardization, to embrace it on a given protocol, right? So that they can focus on the really important stuff.
Well, let me give you an example of how it can be personalized and protocol-driven. So my wife was diagnosed with stage 3A breast cancer in December of 2011. I oversee the medical records of 3 million patients. Wouldn't it be interesting to look at all Asian females, age 50, who've had stage 3A, HER-negative, ER progesterone-positive breast cancer, and ask what treatment did they receive and what outcomes did they achieve? And so it's, yes, big data analytics driving a population solution for a person. And that's actually what we did. And so we actually found that the combination of Cytoxan, Adriamycin, Taxol seemed to actually work very well for this style of tumor in Asian females. And she was given that chemotherapeutic regimen totally fine. She's now cured, in remission, et cetera. And I hope we see more of that. I mean, it's not that we can directly apply anecdote data for a large population to every person, but it's certainly interesting to inform, in this case, personalized cancer care.
So I mean, that's an application, not for performance management, not for clinical decision support, but actually it transforms the system from being evidence-based to evidence-generating, so you can actually improve. There was, I think another thing that you mentioned, Barbara, in our earlier conversation was around how if the systems are in place and enabling quality care to be delivered, so the IT systems are in place, that opens a new vista for the healthcare professional, which is perhaps as engaging and as maybe is a way of putting the joy back in, which is around having them take the role of being a clinical process architect, or it's a new type of professionalism that, in addition to the one-to-one patient care. And I think you were discussing that this is something you're developing in the Innovation Center.
Yeah, we're working really hard to look at all the variables of the system and the flow. So I mentioned that we have a lot of work going on, what we call our Center for Innovation. We have a big platform and a portfolio of projects in the Mayo practice. And so we actually have a lab where we're trying to prototype with real doctors and care team members and patients new ways of looking at the processing of information around decisions and how it impacts clinic flow. So it's really been interesting to try to look at roles and responsibilities. You can imagine when you bring surgeons into a space like that versus internists. I mean, there's so many different models we have, even at Mayo. There's so many things we haven't figured out about how to optimize the contribution of the physician, how to think about optimizing and bringing everybody up to their licensure, the role of other members of the team, and what new kinds of roles we might need as we think about the overall flow. So I don't have a sort of finished product to share, but the work's going on. We actually call it our smart space. It's sort of smart space to try to sense and understand and think about optimization of flow in the clinical practice, and we're pretty excited about some of the things we're starting to see. Also, just to react to a comment, we this whole thing, I think, about the algorithms and the standardization. We've been building something that we call Ask Mayo Expert, AME. Actually, cardiologists with iPads are the ones that got started on that. So we have a lot of people running around with iPads. And that's another conversation about all of the technologies that people are, the bring your own device thing and smartphones and everything else. And many people that want to use their personal devices, not just sort of Mayo endorsed devices, as part of the overall conglomeration. So we can talk about that. But the Ask Mayo Expert is trying to think about, how we can share what Mayo knows. So clearly, with 4,000 physicians and scientists and the depth of clinical knowledge, how does a rheumatologist in Mayo Clinic Jacksonville understand a rheumatologist who's completely specialized in rheumatoid arthritis in Rochester? So we're really trying to get into the heads of our physicians. We've done a lot of work in building out sort of protocols and ways, guidelines, I should call it, to really advise and help physicians and providers in their decision making. And even that, the experience about accessing things like clinically vetted knowledge that our own clinicians have helped us to do. When you examine physicians doing their workflow, if you have to leave the EHR in this application to go over here to look at your imaging, to leave here to go over to AME, if Ask Mayo Expert advises you to do something like this, maybe it's that the specialist should actually get directly engaged with the patient. Well, maybe it's one of our e-consults we've defined that they don't need a face-to-face visit, that we could bring the physician in and provide a different way of accessing the knowledge. Those things are not integrated in a way that makes it easy for the physician during workflow at the point of care to process all of those things and try to figure it out in a way that works best for them, for the patient, most importantly, but also an efficient way for them. So there's a lot going on in the flow that we're really trying to better understand, and roles and responsibilities of team members.
And you're engaging professionals in developing.
Definitely.
As you describe, there are new models in which patients, families, and doctors interact. So we've been sharing all the data about patients with patients since 1999. For about the last 4 years, we've been sharing all the notes that doctors write. So that is nothing about you without you. And so you can imagine, if any of you have read a doctor's note, not only is it very challenging to understand at times, but sometimes doctors don't write them in the most friendly fashion. If, I'm seeing this depressed, overweight man again, so hence we had to rethink how we were going to write notes and store data, assuming that patients and families would read it, would comment on it, would be part of the shared care plan development process. So instead of thinking in the what I'll call historical, patriarchal, I am the doctor, let me tell you what I know and you will be fine. It's how do you build a care team with patients and families working together and bi-directional patient-generated data and sharing the full record with the patient. And that does bring some of the joy back.
Yeah. We're finding that, I just wanted to add on to that, in our smart space and the experiments that we're doing, that the idea of really documenting, dictating, whatever it is, natural language processing is not where it needs to be yet, at least at Mayo. We're trying lots of different things, but that would always be done, with a patient and family members if they choose that. So it's not something we do after the fact. It's how we make that conversation very open, and that becomes an opportunity, for conversation and clarity that becomes very, very important.
It's so refreshing to know that all the problems at Mayo are the same problems I have. So that's good. You've made my day. Because NLP is a technology that we use, so we have unstructured data as well as structured data. And if you want to do big data and data mining, when half your record is free text, that's hard. And so here's a sentence for you. Doctors write in most of them, anyway, I'm sure yours don't, but mine do, in grammatically inappropriate sentences. So things like, the patient whose mother had breast cancer is doing fine. Now, so when an NLP engine reads that, it says the patient breast cancer, right? So trying to tease out what is the subject, the predicate, and the object in a lot of these sentences is quite hard. I'll give you an exact example from my wife's record, because we actually use my wife's record in the NLP engine to test it. It said things like, well, this patient had a 40-year history of normal menstrual periods, was given a bunch of adriamycin, Cytoxan, and other nasty chemotherapy, and is now amenorrheic. So the natural language processor sees, 40 years of normal menstrual periods, then sees amenorrhea, but it has no idea how temporally those concepts are related. So what you end up with when you have structured data analytics is all this junk where it's negated, it applies to somebody else, it's temporally inaccurate. So we're seeing about 80%, roughly, precision in the NLP processing tools, which means 20% of the data is wrong. That doesn't work so well.
And I think that's really where a lot of innovation will happen. I mean, we can make good IT systems. We can integrate all these legacy things together. We can even paste things on the front of them and make them more easy to use, right? I mean, we can, granted, there are some challenges with certain systems, but we can make them easier to use. We can deal with silly complaints like log-on times, which is the single biggest complaint that physicians have with using an electronic medical record system. But the yet to be invented is how, now that you have all this really rich data in one place, how do you make use of it? Because that's new science. It's new algorithms and how you dig into this non-grammatically correct, mixed scientific medical jargon that really confuses computers. But if you can crack, the more progress you can make with that, you can then distill down insights that you present to someone providing medical care, and maybe it'll direct it slightly in a better direction, right? And that's in the yet to be invented area.
But I'll tell you, I mean, this is very hard. And let me give you another silly example. My wife's example was a good one to say that we were able to look at a cohort of 3 million patients and look at breast cancer treatment. But you have to be very careful because sometimes the nature of the data we gather in healthcare varies over time. Its accuracy and granularity vary over time. So we did a study and we looked at the normal human white blood cell count. We found something fascinating. Do you know you guys wake up in the morning with a white count of 5, but at 2 in the morning your white count is probably about 11? Well, that makes no sense. I mean, as a doctor, white count doesn't vary around the clock. How many people have their blood drawn at 2 in the morning? Oh, that would be sick people. And so the data will suggest something that's just absolutely an artifact of the way we gather the data to begin with.
So, I mean, I know we're here talking about the Affordable Care Act and we want to take a US perspective, but some of the things we're describing are very, very high-level advanced uses of these sorts of technologies. Well, when I travel around and speak to often SMEs that are setting up clinics in emerging economies and stuff, they're really working from a baseline of the first step is literally to go paper. The idea is to put it into a health record so they can reduce the amount of paper. Then there's steps that follow on from that. Is there a kind of narrative? Does one go from that suddenly to the kind of things you're talking about? What are the steps one takes if you're sort of setting up like that? And especially if you may be burdened with some legacy stuff as well. What are the steps along the way and the levels of sophistication and functionality?
Well, hey, I don't want to monopolize, but do you want to start?
I would say starting, if you're starting from scratch, you may be in a better position than if you're starting from legacy. Yeah. Only because legacy systems have data in a particular format, and you want to put data from different systems together, your tests and radiology and clinical history together so that a physician can actually have an integrated view of a patient. So starting from scratch in that sense could be easier because you're going from one point forward. But it's interesting, in the smaller, we're not so far ahead of the world in the US, except in spending too much money on healthcare.
We're good at that.
We're very good at that. We excel, we lead the world in spending too much money for getting poor results. But if you look, it's the same problem for a small doc practice outside of a major urban area or a community hospital. It is as simple as, let's get stuff into a computer so we can have it all in one place, and I can easily see a look back in time, have a view of a patient without having to flip through some paper. And by the way, now, because meaningful use requires me to be able to share data, I can actually have continuity of care. So I remember when we had my first child, we took a folder of paper from the OBGYN to the hospital and gave it to the doc there in the hospital. That was data data motion 9 years ago. And unfortunately, we're still in that in many cases. It's the same problem in the developing world, but there are many places in the US. Now, we've made a lot of progress in the last couple of years because of stimulus dollars have driven people to make investments in this country to actually use computer systems to manage their practice and store electronic medical records in, right? And so that in itself is a foundational element which is just finally getting there in the US. But interesting to the conversation we'd had before, in the developing world and in the US, the smaller institutions, they're starting with not the traditional route, which is let me buy some computers and buy some software and set up something, is they'll look for how can I get it through the internet first? And that's very interesting, and I think very much a future business model of healthcare.
I really appreciate that comment. Just to tag on to that one, what we try to do in the prototypes and the experiments and such that we're building out is to not let the state of the electronic health record and the sophistication get in the way of just trying to prototype a model that will deliver better health and better care. So for example, we actually worked with a small practice in northern Minnesota. We wanted to pick a practice that was hundreds of miles away and one that really had an interest in how can we try to keep patients and people at home so they don't have to go on to the tertiary quaternary level facility unless they really need to. And this happened to be a practice that didn't have an EHR, but they had internet connectivity. And we said, okay, we can go ahead and create a connection into our portal. And we can try to understand for the general internist, for the family practitioner, for the nurse practitioner, for the physician's assistant, what is the kind of question that they have for the specialty practice, and have the integrated practice answer back. And so that was just, it's a model that we just tried. And we said, okay, there's internet, we can make that work. And we were able to sort of start that first proof of concept in something that wasn't very sophisticated. And I'm just so proud to look back on that story to see what we've done and how it started. It wasn't, okay, we have to match up, again, sophistication in EHRs and other things to prove out that this could be the kind of model we could move forward with. And we found in that model, just to finish the story, that 85% of the patients that we served could stay home in their community. And the 15% that needed to come on to a place like Mayo Clinic, we were teed up and ready for them because they needed a bone marrow transplant, they needed a procedure. So you can imagine our surgeons and our providers, our physicians, not needing to use, I don't want to say wasteful office practice time, but really, if we can connect that in a new way and try to understand in partnership with primary care providers, there's a lot of opportunity in that kind of model.
So you asked, what is the journey that we're on? So I would say the paperless hospital is as likely as the paperless bathroom. I mean, it is, in Japan, I hear they're doing that. But we start with doing a Pareto analysis. So what are those workflows that will be amenable to electronification? So that is problemless management, medication management, e-prescribing, allergies, labs, radiology. But the notes, those are still messy, and sometimes notes are on paper, and sometimes consents are on paper and scanned. And so you're going to have this long tail on digitization where you try, with meaningful use, as you said, to start getting the basic data elements in. What we did, sort of similar to your observation, is we found that a cloud-hosted approach was far easier to implement in doctors' offices, especially small doctors' offices. The notion of maintaining a server in an office is dead. I mean, it's just too expensive, and security issues, et cetera. So we built a couple of cloud computing centers just purely because at that time, no cloud provider would sign a business associate agreement. So we really had no choice but to build a private cloud. And then offered at very low cost, with an 85% subsidy allowed by Stark, all the physicians in our community to use a cloud-hosted record. So that started getting the data in. We got them all meaningful use stimulus dollars. Once the data's in, then the data sharing begins. As you say, meaningful use stage 2 encourages sharing. It's doctor to doctor, doctor to hospital, doctor to patient, all these elements of stage 2. Our state, I mean, for those of you from Massachusetts, we have a state healthcare information exchange which has all the meaningful use stage 2 federal standards baked in. So you can do doctor to doctor, doctor to hospital, doctor to patient exchange through a state-funded infrastructure at very low cost. That's been used to create various novel aggregations of data. which get us to the next stage, and that's the analytics and the feedback and the decision support and hopefully discovering new knowledge, clinical trials, clinical research, and enrollment in some of these new treatment ideas. And so, Obama plan was 2010 to 2016. It may take a little longer than that. There are some challenges with healthcare.gov and a few other things that we've tried. But I will say that in the last 4 years, it feels like we have doubled the amount of electronic health record adoption and healthcare information exchange in many regions in the country. It's not everywhere, but I think we've made pretty good progress toward this goal.
And can any of you talk about, in terms of what it enables? There's been a lot of drive towards, and this is international, towards integrated care. So we're actually linking up prevention with primary, with secondary, and having continuity. You've got some case studies or insights into how this is happening and how that's being enabled by these sorts of technology systems.
Well, I'll start by saying there's a statistic. 30% of any type of medical test in the U.S. have been done before.
Come on, in Massachusetts, it's only 15%.
I'm averaging across the entire country. It's only 15, but that's.
But we spend more than anybody else in the whole United States, so 15%.
It's billions and billions of dollars of tests. So I'm not even talking the quality that can come from having continuity of care, right? Continuity of information as a chronic, especially a chronically ill patient goes through the healthcare system and visits different sites and institutions. I'm just talking about wasting money, redoing tests because they're not easily transferable or movable, they're on film, whatever it may be, right? That's just money that is going down the drain that can't be used on people that are sick. And that's just the most basic. That's not even looking at correlations of looking at quality of medicines that could be prescribed by two different physicians that cause an adverse reaction. That's not even that's another simple item. That's not, but the quality measures that come with, and this is part of meaningful use, right? And this is why having a continuity of care document is an important part of this data exchange, is that you now have more of a standard language that you're moving data around, and you can actually start to measure the impact of quality by having data follow you around versus walking into a physician office, filling out a paper form on what you dealt with that doctor on the other side of town, and dealing with all the handwriting and you translating and providing the medical update in some cases, right? It's terribly frustrating. John, I know you spend a lot of time looking at recommendations around meaningful use. Can you talk about some of the quality that comes from continuity of care?
Well, sure. So a couple of examples for you. So at Beth Israel Deaconess, like many hospitals that are tertiary referral facilities, we have high readmission rates for patients like congestive heart failure, COPD, these sorts of things. So we received a CIMI grant, so an innovation grant from CMS, to look at why we were getting so many bounce backs. And of course, the right answer is our patients are sicker. Right? That's true. So every doctor will tell you that. But we were able to develop a model that said, what are the characteristics of patients that are likely to result in readmission? And what we found is a lot of it had to do with lack of coordination of care post-discharge. So that you show back up at the PCP's office 2 days after hospital discharge. So why are you here? Oh, you were in the hospital? Oh, news to me. And so we started building these predictive models that suggested what behaviors we should initiate on admission, not just on discharge, that would result in readmission rate reduction. And so that is notification of admission to primary care physician, following up with that physician with care progress and care plans, sending discharge coordination plans. You again engage patients and families, and suddenly we're seeing reduction in readmissions, more health and wellness in the home. And we also did some odd things like, turns out ventilator-associated pneumonia, or surgical site infection or catheter infection, rampant in hospitals, nosocomial kinds of things. Try telling your physicians, you know what, new compensation plan, 20% of your pay to is linked to the number of nosocomial infections in your hospital. It's amazing. Our infection rate is now 0. How did that happen? And so by doing not only care coordination, as you say, but analytics and near real-time analytics and providing feedback and compensation incentives around analytics, you can significantly change quality and cost.
Well, that's really about incentives, right? I mean, with healthcare reform, I mean, you will not be paid for readmissions in certain cases.
Exactly.
Right? I mean, it's very simple. You will not be paid for the costs associated with some hospital-based infections. I mean, and then you put that in the incentives for the medical community, you get the expected response. I mean, it's capitalism applied to healthcare.
Well, so here's a ridiculous case for you. This would never happen in the UK, I'm sure. But my mother broke her hip in October of 2011. The physician at the hospital, good hospital, meaningful use, stage 1 user of a major commercial EHR, had no access to the medication list of her primary care doctor in the community, even though the primary care doctor was 1 mile away. There's no way to get that information. So asked my mother to bring in every plastic pill bottle she could find in the house, because that would be a good proxy for medication list, right? So they put her on all of them simultaneously. And by the time I got out there, because she's in LA, she was like sitting in a corner going, I mean, she was like completely incoherent. And so a nurse handed her a glass of water, and she aspirated and developed an aspiration pneumonia and was in the hospital 5 days longer because they had over-medicated her, and they were paid for the error that they caused. And of course, as you say, we shouldn't pay for nosocomial infections. We shouldn't pay for readmissions. We shouldn't pay for mistakes hospitals make that result in patients staying longer. We need to realign those incentives as well as improving interoperability.
Well, I've got a lot of questions I could ask, but I'm cognizant of the fact that maybe all of you have questions for our panelists. So I'm going to open it up now to the floor. Does anyone want to kick things off with a question?
It's a shy group.
Well, somebody must have a question. There we go. Can we get a microphone over here, please? Thank you.
So we haven't yet talked about privacy, security, BYOD.
No, that was my next question, but I thought someone was...
I'm interested in a remark that Mr. Calhoun made early on in the presentation about, what bad shape your typical hospital or doctor's office IT system is in. How did the IT revolution miss, 16% of the U.S. economy? I mean, I don't think you'd have that problem at General Electric or DuPont.
Well, I certainly have some opinions. I mean, well, one's just lack of money. I mean, when John should talk, but when I talk to people in John's seat, when they go to a capital committee saying, we need to buy some computers for an electronic medical record system, they're in front of the capital committee competing against the radiology department, the pathology department, and everybody else to buy things that are more directly linked to driving revenue and patient care. Now, IT is an essential part of making all this happen, but it's unfortunately about 2 steps removed from that. And so when you have a health system which is run on 2% margins on average, that's in a good year, right? And will be compressed now with reduced reimbursements. It's capital starved. It is grossly underinvested in. We have millions of devices either in the field today. Our healthcare customers have the oldest average device of any industry around. They sweat these assets to death because they are so capital starved. So it's just 18% of the economy, but a much smaller percent of revenue is spent on IT with the resulting outcomes of data centers behind kitchens and under pipes and all kinds of crazy things like that.
So let me give you a visual example. At my last Capitol Committee meeting, the urologists brought in the rusty tools they use for prostatectomies and said, we want a Da Vinci robot, $300,000. But if you don't fund it, here are the rusty tools we'll use on you. It's like everyone was starting to pull out their Visa cards. And I said, oh, and I, by the way, need a few laptops and tablets. Da Vinci robots sounding really good. My capital budget, my operating budget, are a fraction of other industries. I have never exceeded 2% of the operating cost of the institution. Fidelity is at 35% for IT. So we underinvest. But then there's this huge misalignment of incentives. So imagine that I decide to build the world's best, user-friendly, highly efficient medical record that prevents people from getting ill. It's going to be fabulous. Blue Cross will benefit handsomely. Every dollar we invest in IT doesn't help us. In fact, in a fee-for-service world, it hurts us. So we're only starting to see with ACA alignment of incentives of he who invests in IT can benefit from IT. So double my budget, realign incentives, then I'll be fine.
Change the culture, too.
That's it.
Change the
That's it.
Question over here.
So I used to counsel alcoholics in the Cambridge Hospital emergency room, and it's not clear to me that incentives do it all. There was one Thanksgiving I was counseling this man, and one of the emergency room doctors came in and said, oh, we have alcoholism services here. I had someone just last night who was about to get the DTs, and I discharged him. Now, he wouldn't have a readmission because this person's out. And so doesn't it take something more than just incentives to get the right behavior?
Well, I mean, all of us as clinicians, of course, want to do the right thing and help patient quality, safety. What I have hoped is that the investments, just as this gentleman asked, will be made in novel ways when hospital administration recognizes the benefit of actually wellness rather than episodic treatment of sickness. And so our healthcare system, unfortunately, for the post-war era, has had a complete misalignment as we went through private insurance and employer-funded insurance to actually ensure wellness. And that's, our model can be improved to encourage this continuous lifetime wellness, and I'm hoping we as a country are in that right direction.
Yeah, I was shocked at one of the statistics that David Cordoni shared with us earlier, and I have to ask him where he came with this statistic, but he did say 70 to 80% of the cost of health care, depending upon the definition, is due to lifestyle choices, which goes back to information around wellness. And that's not just the physicians and how we keep people well, but it's consumers as well, right? If there's information that people can have around what's good to eat, what's good to do, what's good not to do, but I was shocked by that statistic. So I'm just recounting a statistic from earlier in the day, but that was surprising, and I'm sure open to a debate and definition.
But let me give you two examples just in exactly that light. So I used to weigh 70 pounds more than I do now. And so I'm 52, so when I was around 40 or so, my doctor said, your body mass index is 31, but don't worry, we're going to put you on beta blockers, ACE inhibitors, Lipitor, you're going to be fine. So wait, $700 a month of metabolic poisons because I'm eating supersized lunches and 2 lattes a day. Maybe the right answer is lifestyle change. And my doctor, who weighed 375 pounds, said, that will never work. You will just lose 25 and gain 35. So being, the typical Harvard professor, physician-driven guy, I became vegan and I returned 6 months later, 70 pounds lighter, and haven't gained a pound in 12 years. And that is a very unusual circumstance. Doctors will tell you changing the body mass index of your patients is extremely, extremely hard. So what I'd propose to your incentive point, safe eating discounts. You get it for your car insurance. Why not, Reward you for eating that broccoli instead of the Boston cream pie. Another place we spend a lot of money is end-of-life care. My father died 7 months ago today, and he died not in an ICU. Wow, how un-American. And it was because my doctor developed a shared care plan with my father, and so we said, If you have multiple sclerosis and a variety of heart issues and a variety of bone marrow issues, the quality of life you will be returned to at any resuscitation will be poor. So, let us together decide on what your personal preferences are for end-of-life care, and how about dying in a respectful and dignified way, surrounded by family in a comfortable place, instead of on a ventilator in an ICU. So it turned out his personal choice actually was the healthcare efficient choice as well as the respectful choice. We don't do that enough because it's very hard for doctors to have that conversation with patients. Yet especially, I'm an only child, my wife's an only child, and we were the only decision makers with my mom. If you have 5 siblings, oh, it's Dad, do everything. Yeah, hard to get to that respectful choice.
I mean, both of you have raised a very interesting. Did you? Oh, you have to go. Right. Okay. Thank you very much. Thank you. Thank you for your time. Thanks, Barbara. So both of you raised an interesting point, which, I mean, going back to the title of this, which is about transforming healthcare with information. I wonder if you had a point of view on how we can use information and the information revolution, if you like, and the technologies to transform patients and the citizen into a healthcare, as being part of the healthcare professional team, to look after themselves and to look after and as informal carers. And where are the boundaries on that? Are there any boundaries on that? And what progress are we making towards that?
So certainly several ideas. As I mentioned, since 1999, we have made available all the data about patients to patients. And 2 years ago, we moved that to the smartphone platform. We've actually created an HTML5, what I'll call adaptive style sheet. So whatever device, if Apple introduces the iPad mini and a half, it'll work on whatever form factor, so that patients and families now have full access to all their information, educational materials, as well as the ability to submit data and engage in conversation. So that helps. But I will tell you, as part of our home care efforts, we're going to see more and more telemetry and patient-generated data. So I'll give you a couple examples. In my father's case, since he had multiple sclerosis, he was on a litany of MS meds. If any of you have either had multiple sclerosis or a family member with multiple sclerosis, you know the side effects of the meds are often worse than the disease. And it's an art, to the comments we were having about art and science. Every patient has different reactions to different meds. So you can imagine a doc and a patient actually engaging in therapeutic conversations electronically with not every 3 months, I'll see you to, how you doing? You tried a med, 2 days later, how's it going? What's your functional status, activities of daily living, pain, muscle spasms, sleep, and then constantly adjusting electronically and bidirectionally via these personal health record and secure email systems, so that you have much more rapid cycle turnaround. At Beth Israel Deaconess, it is a requirement of every multiple sclerosis patient to be a personal health record user on our system, because that is the way that medication management is done. I expect as well that we're going to start doing things like electronic bathroom scales, spigomanometers for blood pressure measurement, pulse ox measurement for COPD, FEV1, all these telemetry elements that you would gather from the home. In the case of managing my parents, and I'm of that age where I get to manage above and manage below, it's fabulous, highly recommended. I would love to be able to say, did mom get out of bed today? Did mom turn on the TV today? Did mom open the refrigerator today? I mean, this is not medical data, but watching sensors in the home would be a proxy for her wellness. And I actually can imagine us as home care professionals interested in wellness doing this kind of thing more frequently. I have seen some interesting iPhone apps. I mean, most of those that are on the App Store, I think, downloaded once and never used again. But the idea that, we are now all carrying accelerometers. And, you take a company like Ginger.io. I have no interest in any company or stock in any company, full disclosure, which actually can look at how many times you tweet or answer emails or look at Facebook as a proxy for your mental activity. Now, not quite certain that looking at Twitter, Facebook, or anything else is really
It's
mental
not cerebral
activity.
activity, it's mental activity.
But yeah, if you normally are clicking 32 times a day, and today you're clicking 0, well, maybe that says you don't feel so well. So these are the sorts of novel data streams I imagine we will gather in the future.
Well, and the tools exist for collecting the information, right? I think it comes down to incentives and actually interacting with family members, sharing information, dieting, good food, all these apps exist. I think there have to be incentives to use them. And if you're chronically ill, you've got a big incentive to use them, because if you don't monitor certain conditions, you could wind up feeling poorly or back in the hospital or worse.
And let me
I will give one example around incentives. Would be we have 108,000 employees at Dell. About a third of those are U.S. employees, and we cover the families of those people and provide them with health benefits as well. We actually have an incentive program in place, so actually you get large reimbursements if you do a health survey, and if you're outside of any criterion, you actually have to sign up for coaching. And if you're above a certain body mass index, you actually will get a discount, if not if you lose it, but if you sign up for a program with a health coach where you talk about nutritional changes, and you actually get a discount if you don't smoke. So I think those actually drive the incentives, and we make applications available to our employees to help them manage their diet. And this employee engagement, we're self-insured, we have an economic interest in making this happen. So back to incentives, we have an interest as a company to lower our costs. Our people have an interest because they actually get substantial rebates on their health insurance. I'm sorry, you were going to say something.
And you're exactly right about the value of engaging patients and families. So there are two kinds of populations we see that are using these kinds of e-health applications. The acute injury. So I have a problem, I'm dealing with that problem today, my doctor and I are interacting today, and then once my problem's resolved, I stop using it. And that's okay, there's nothing wrong with that. The other is the chronically ill. I'm having a problem every day. I better interact with my doctor, my home glucometer, my medications, or whatever. So when I say of our 250,000 patients, 60,000 use these apps with us every month, it's a different 60,000 every month.
We have a question here from the audience.
Yes, Paula Buick. I'm a nurse and I work with Beth. I'm wondering about, as we're talking about big data and technology, I see them very applicable to people like me, but I work with hospitals all the time and community centers, and I'm just wondering about our disparity chasm and how are we going to, really try to permeate and have some of the population that we see in our hospitals today really sort of benefiting in their socioeconomic.
I think that's a really back in the UK, equity of access is a kind of key organizing principle. And if someone says this is going to make healthcare inequitable, that actually stops that initiative from taking place. So I think this is a really interesting question.
And so here's what we found thus far, is that 75% of the Medicaid population in Massachusetts has a smartphone. So it may not be a desktop or an iPad, but you actually can do SMS texting kinds of things back and forth, and that's a way of reaching patients. So what we try to do is gather the information from the patient, their preference for communication, recognizing that some people will do interactive voice response on a phone that's not capable of anything but voice. Some people will be able to get texts or be able to engage in web applications. Some people want paper. And so what Meaningful Use suggests is that we are supposed to gather that communication preference of the patient and support multiple modalities. It's not perfect, as you say, there's still a gap. But the way we've architected our systems, they can be used in any public kiosk, any public library. Because they're all browser-based and client. They're just neutral to where you're accessing from. Language, there's a challenge. There's 37 different languages used at Beth Israel Deaconess. And so when we take our patient educational materials, there are 5 or 6 languages that we typically translate everything into, but it's not quite 37. So, As part of meaningful use, we gather the demographic information on race, ethnicity, primary language, age, and are able to stratify our quality indicators to get a little feedback. And as you point out, there will always be some digital divide, but at least at the moment, it seems like the phone is becoming a commonality for delivering information.
I would add that providers, there's been a socioeconomic divide in providers as well, because rural community hospitals, inner city backstop hospitals don't have the resources, have historically not had the resources to have great IT systems that allow you to then have the patient engagement, right? Now that everybody's got a computer in their pocket. But the new way of delivering IT that many institutions are now adopting, we have thousands of doctors using our physician cloud. We have 60 hospitals using our Meditech cloud to run their institution. That's a new way of getting IT that doesn't, again, require you to go to the capital committee and ask for a big investment so you can go hire a consultant to go create an IT system for you. You can rent it. And so what it does is it provides the access to those advanced technologies out to a wider range of providers as well. And while not perfect, and there's a lot of catching up to do, I think the trend is very positive because it does come down to affordability and access at the provider level too for those advanced information tools.
And certainly cloud hosting is a very good idea. Our existent EHRs in America today are typically delivered via VDI or Citrix, which I do not consider a cloud hosting and mobile option. So there's room for innovation for sure.
It's been a flurry of hands. I'm going to go this way around.
So we've talked about a lot of different IT vendor and vendor types. It's always tempting to beat up on the EHR vendors, but I wonder if 3 to 5 years from now, we'll be looking at them as significantly bigger companies because they're in pole position to bolt on additional functionality. Are they in the best position to structure this data, or can they just be consigned to being a front end for capturing the data?
Well, the fun thing about predicting the future.
So I can tell you it's a complicated question. EHR vendors are not the most modular nor the most open. I mean, I love EHR vendors. There's some very good people and good technologies, and they're trying really hard. But what if this could only host apps written by Apple? That's the state of EHR vendors today. I mean, there are a few EHR vendors with open APIs that allow an ecosystem of young, talented, garage-based developers to create novel add-ons. And of course, all of us in the industry are trying to create new open source technologies and ways in which we can take data out of monolithic EHRs and then enable this kind of innovation. But I think it may very well take meaningful use stage 3 or some regulatory action to get some of these legacy systems opened up a bit more.
And you can contrast that with if you go to something like the Health Information Management Systems Society, which has every health information vendor you'd ever want to see. There's always thousands of new vendors every year, startups with new angles on IT and new technology. But then you contrast that with some of the massive amount of investment in electronic medical records, particularly in hospitals, but also in physician practices today. Those are sunk dollars, and those are 10-plus year investments. So I think you have to contrast all the innovation, all the new things, new delivery models with, if you just spent 10, 20, 50, 100, I know customers that have spent in excess of $1 billion on implementing an electronic medical record system, that's going to be there for a while. You're amortizing that asset over a really long period of time. And so kind of ripping that out is, I think, probably not possible or probable. So I think it's hard to say. They're in a position because they have the data for affecting great change and doing wonderful things, but it does require easy movement of that data to other systems.
One danger that we have is we see that regulations have caused adoption. That's good, but they've also created a barrier to entry for small startups that are trying to develop certified modular systems. Actually, I've had many vendors contact me and say, I give up. The barrier to entry is so high, let's just let Epic, Cerner, and Meditech figure it out. And those are great companies, but they're not well known for their iPad apps.
I had a question about security, because so over the course of the day and other events like this, it's fantastic to say that you're building systems that you can send data across the building, or from the hospital to Walgreens, and everyone can talk to my smartphone, and that's fantastic. But the one thing that no one's really talking about is the security, and how, if at all, you're staying hopefully ahead of the curve on security, because you're saying that you're spending 2% on your infrastructure versus Fidelity that's spending 35%, yet I can get a card from a credit card company that I didn't ask for because, oops, our data was compromised, so here's a new card just in case. So can you speak to how you're staying ahead of security with all this fantastic data sharing that's going on, that's in the works?
As August well knows, welcome to my life. So I have this very peculiar thing that wasn't in my bio. So I may be CIO of this or that, professor here or there. I'm also the guardian of the medical records of both the Tsarnaevs. So when you think about the Boston Marathon bombing, both of those individuals came to Beth Israel Deaconess, and I am the holder of their data. It's interesting that I have 2 million patients to protect. It's a little bit more interesting when I have every hacker in the world trying to get at data that I hold for various reasons. And so the level of attention to detail around security best practices in my organization, especially over the last year, has been such that there were no new FTEs approved basically in the organization except for IT security. And so this year I have a $5 million capital budget. I have 14 new positions because this is an area where there's a Cold War. You would not believe, well, you would believe because of Dell SecureWorks, the level of sophistication of the attacks that are coming in today. These are not brute force password guessing kinds of things. These are people trying to engineer social media delivered malware to get at targeted individuals, to compromise their smartphone, to scoop credentials, to log in. I mean, it is an unbelievably challenging area. I have a multi-layered defense. I'm spending millions. I have lots of people. It's one of these things where the work will never be done, and all I can do is make it my top priority, which is what I've done.
If I could comment on that issue as well. I mean, perfect security is I guess, basically impossible, isn't it? And I think if you think of IT systems or the infrastructure as being a medical intervention, we accept that drugs have an adverse event rate, and we accept that. And I think if we're trying to compare, and this is also trying to improve outcome for patients. So there's an adverse event rate with this too. I mean, that's the way I kind of look at this thing. And it's not to trivialize these issues. It's very, very serious. But we have to accept that if you want good outcome, you have to accept some risk. That happens in everything in healthcare. That's just my point of view. But, yeah.
Right, and everything that we do in security is a risk analysis, as you describe. I have the challenge of, I have 3,000 doctors, and those doctors need access to patient records appropriately to deliver safe, coordinated care. And what if one of those doctors is traveling in China and is using a shared hotel computer? Do you allow it or not? And so in our case, we've used adaptive authentication that says, oh, coming in from an IP address in China, that's odd. No, we are not going to allow you to use your standard username and password. We're going to send a PIN code to your known registered cell phone and require you to log in through a special secure portal. So there's a layer of security that's added because of the nature of the data, your geographic location, the nature of what it is you're trying to do, those sorts of things. And, without having a priority as to what is the business imperative and the risk, you might as well just close us down. Because the most secure library will be one that never checks out any books. Can't quite do that.
And it's reputational for us as well. We have over 20,000 servers that we manage for various healthcare organizations, 12 petabytes of data. It's like 7% of every medical image in the United States is actually in our data center. So we have a lot of sensitive data. And we actually bought what we thought was the best managed security services company, partly to protect all of the healthcare data that we had. And we turned that around and we monitor ourselves. We are doing regular intrusion detections, looking at all this, the attack signatures. We see over 4 billion events a day. So
and
it's
only
incredible.
2 billion are from my network.
We've got about 4 minutes left, so one last question probably.
Okay, my name is Kristen Anderson. I work at a innovation management consulting firm in Cambridge. I have a two-part question, one for each of you, but it's based around the concept of innovation. And it's been used a lot today, and it's been tied to things like big data and mobility and technology-enabled type tools. But my question is, from the industry level at Dell, those things are sort of in the past. As much as they are being implemented right now, they're not new. We've heard from a number of experts that these things have been around for about 5 or 10 years. So what are you doing at the industry level to innovate for the next generation? And then at the more granular level in a hospital, how are you making sure that you're not investing billions of dollars in a technology that might not be the forefront, right? So we talked about the iPhone, but the iPhone is very current, and I don't believe it's what will be 5 or 10 years in the future. So how do you make sure that you don't spend all this money in apps when that's not what's next?
Good questions.
Well, I would say that when we look at the healthcare industry, what I refer to it as we like to build the foundation for the future, which is a flexible foundation that you can, without having to go rip out IT systems, and when somebody makes some technology decision that you have to support, how can you build something that looks and walks and talks like a private cloud so that you can just bring in things, drop them in, use them, and get rid of them when you want to? And more importantly, this is typically the stumbling block, is how can you make sure that when you want to get rid of something that you can easily get the data out of it so that you don't have to keep it around forever. You want to get the data out so that you can then make use of it and then so that you can then walk away at some point. And I think that's often overlooked, especially in healthcare. The amount of time, money, effort, sweat, tears, pain, blood that is spent on getting data out of old systems is just maddening for IT professionals. So I would say you have to look at how do you build something that that can grow and scale and support a variety of flexible new systems, and then how, when you make another decision, how can you make sure that you have access to the data from your old system? If you look at it like that, then you're kind of making more informed decisions then around what you build as a foundation, and then contingency planning around, I'm making a decision for this today, but how do I want to, if I want to get out of it at some point in the future, what's my path out of it that doesn't require me to hire 100 consultants at an ungodly rate and pay a lot of money to get that done? That's my view.
So to your point, at the granular level, standards are something I do have control over. So as a CIO, I actually have unbelievable accountability and almost no authority. But I can say, to your point, we actually think Flash and Silverlight are horrible technologies because they actually tie you to a client-side platform that over time may be deprecated. So HTML5, well, hey, it may become HTML6 or 7 or 8, but the likelihood you'll be able to have a browser-neutral, platform-neutral, iPad or Android device in the future rendering HTML, oh, I think that's pretty high. We happen to be the pilot site for Google Glass. And as a procedure-oriented physician, it's very common. I'll walk into a patient room. I have to use my hands, but I also need data about them. And grabbing your smartphone while you're gloved doesn't work so well. So we believe, again, it's going to be HTML5 only. It happens to be the platform in the moment. Could be new wearable computers a year from now. Who knows? But what we create today will not only run on Google Glass, but it'll run on whatever you create a year from now. Standards, good thing.
And on that note, we do have to wrap up. The alarm went off, you may have heard it, before we turn into pumpkins or whatever. So thank you very much. Thank you for joining us, and thank you for participating.